Hi, my name is Chanel Elkins, and for the signature assignment, I decided to look at an article that studied the norovirus disease incident rate in the United States. Norovirus is an extremely contagious virus that can be contracted from an infected person, contaminated food and water, or by touching contaminated surfaces. It is recognized as the leading cause of endemic acute gastroenteritis. The virus causes your stomach, intestines, or both to become inflamed that leads to its signature symptoms of stomach pain, nausea, vomiting, and diarrhea. In addition, it is also the leading cause of illness and outbreaks from consuming contaminated food and water. There needs to be greater recognition of norovirus since it has increased because there continues to be a high incidence of reported outbreaks. While research has been done about the norovirus, no study has assessed the norovirus disease burden, which refers to the annual number of illnesses and associated outcomes. The study requires a population-based incident rates from national or nationally representative surveillance. By comparing the different methods employed in this study and the results, it provided a summary of the estimates of the overall U.S. norovirus disease burden, which included specific estimates by age, groups, and disease outcomes. This review facilitated the identification of groups that would most benefit from prevention strategies and that are aimed at controlling the norovirus, as well as provide the greatest development of appropriate interventions, including vaccines. To assess this issue, a study was conducted based on U.S. incident rates. They were hoping to confirm and estimate the peak incidence of norovirus infections. This information was used to estimate the total burden by using different methods. It identified main groups that prevention strategies aimed at controlling norovirus and development of intervention. I just read that. Norovirus is most contagious and most likely to spread the virus during the first few days after recovering or when you were sick with the illness. This study demonstrated the predominant role of the norovirus in causing foodborne disease and became a widely cited U.S. article that explained the disease burden in the U.S. Annual norovirus attributable proportion from single community-based study, and it was applied to the U.S. all-cause acute gastroenteritis incident. Endemic norovirus occurs all year round with a significant peak in the winter, which increases by 50% when pandemic strains occur. The two methods employed in the study to conduct the study includes laboratory-confirmed population-based surveillance and attributable proportion extrapolation. Laboratory-confirmed population-based surveillance provides the most direct assessment of the disease incident. This technique employs passive sampling strategy in a population-based study of acute gastroenteritis incidence among outpatients. Surveillance for the laboratory-confirmed norovirus disease provides the best direct assessment of these incidents. What they did was they got a sample of fecal specimens that were submitted to their doctors for routine clinical diagnostics, and these results were allocated for norovirus testing. By using this method, they came up with the following results. Outpatient and community incidence rates for the norovirus were 64 out of 10,000 people in the population and 650 out of 10,000 in the population. When this was applied to the U.S. population, it corresponded to a national estimate of 19 million illnesses and 1.9 million outpatient visits. Annual norovirus hospitalizations, ED visits, and outpatient visits were at a rate of 7,141, which corresponds to the same as 319 out of 10,000, and this is in children that are younger than 5 years of age. Their study mainly focused on the incidence of norovirus in the young population and the older and the elderly population, as they have the highest incidence of contracting the disease. And also, corresponding to the annual rate of all the norovirus disease infections. The total amount for hospitalizations and treatment came to a total of 273 million associated treatment costs, and this is for children that are younger than 5. The next method employed was attributable proportion extrapolation. This method was used to estimate the proportion of acute gastroenteritis attributable to norovirus, which is then extrapolated proportion to all-cause acute gastroenteritis incident. It looked at the prevalence of norovirus among persons with acute gastroenteritis in the community, outpatient clinics, emergency departments at hospitals. That they came up with the following results. Hospitalizations or ED visits for acute gastroenteritis in children younger than the age of 5 pulled a proportion of 12% of cases that was attributed to the norovirus. The prevalence was then extrapolated to national estimates of acute gastroenteritis in children younger than the age of 5 and came up with annual estimates of 235,000 outpatient visits, 91,000 emergency department visits, 23,000 hospitalizations associated with the norovirus in the U.S. in children less than the age of 5, and it suggested that the norovirus is the second leading cause of severe gastroenteritis in children, following the rotavirus. The conclusions obtained by the scientists supported their original hypothesis. The totality of the results came to this for the scientists. 570 to 800 deaths, 56,000 to 71,000 hospitalizations, 400,000 ED visits, 1.7 to 1.9 outpatient visits, and 19 to 21 million total illnesses each year in the United States. On the basis of these rates of disease and estimated a life expectancy of 79 years, a U.S. resident would experience 5 episodes of norovirus gastroenteritis in his or her lifetime, and an average lifetime risk for norovirus-associated outpatient visit, ED visits, hospitalization, and deaths of 1 in 2, 1 in 9, and 1 in 50 to 70, and 1 in 5,000 to 7,000, respectively, through age-specific group analysis. Americans greater than the age of 65 have the greatest risk for norovirus-associated deaths, and children under the age of 5 have the highest rate of norovirus-associated medical care visits. In addition, it consistently observed throughout all the studies, it observed an increase in norovirus disease during the winter months and during years in which pandemic strains emerged. This suggested to the scientists and those conducting the study that for a vaccine to have a maximal impact in the community, it would need to demonstrate safety and effectiveness in young children and the elderly population, since those are the most affected group of people that contract the norovirus. While the study had many positive attributes, it also had its limitations. One of its weaknesses was using the laboratory-confirmed population-based surveillance. While this method provided convenience for those who studied it, it required relatively little sources, and so it has the potential to be subject to biases. One of those first biases is that those fecal samples that were taken had a physician order for bacterial culture were tested. Second, data may have been limited generalizing ability because the study was conducted in a single, relatively young, and privately insured population. However, its strength was using the indirect attribution from regression model. They use population-based databases using international classification of disease coding that are often used to estimate trends of specific syndromes or pathogens. The coding for specific pathogens is actually usually used when there is laboratory confirmation, but given the limited availability of direct testing for norovirus among sporadic acute gastroenteritis cases, norovirus-specific coding in these databases is insensitive and unreliable. To overcome this issue and still use the large amount of sources of data, they conducted a series of modeling studies to indirectly estimate the proportion of cause unspecified acute gastroenteritis likely caused by the norovirus. What they also found was that in the winter months, norovirus peaked with 63 to 73% of all norovirus associated events occurring during October to March, and increases by 50% during years of pandemic strains of norovirus when they emerged. I chose to critique this article on the norovirus because I have suffered from food poisoning more than one time, and that was when I first heard of the norovirus, since I was suffering from its significant signs and symptoms of stomach pain, nausea, diarrhea, and vomiting. I found this study to clearly explain the relation between the incidence and disease burden and the norovirus. Its methods were clearly explained and provided results with sufficient supporting evidence to their conclusions. Thank you.